So, good evening, everyone. Today we have with us Dr. Debdeep Dey, and he shall be speaking today on the Pursuit 2B lymphnodal pathology, which is approach to the spectrum of low-grade B-cell non-Hodgkin's lymphoma. Dr. Deb, please take over. Thank you so much.
Thank you, Dr. Nadeem. Good evening, everybody. Today I'm going to speak about the spectrum of low-grade B-cell NHL. Some time ago, I had given a lecture about approach to lymph node along with basics of immunohistochemistry. Today, we will discuss the various spectrum of low-grade B-cell non-Hodgkin lymphoma and what are the pitfalls and what are the things to be careful about when making a diagnosis of a low-grade B-cell NHL. So what is exactly a low-grade B-cell NHL? It is a morphological designation to a group of B-cell lymphomas which are composed of a clonal population of small lymphoid cells. The WHO classification is based on a constellation of clinical, morphological, immunophenotypic, and molecular genetic features. Low-grade follicular lymphoma, the marginal zone lymphoma, and CLL, SLL show indolent behavior, while mantle cell lymphoma and high-grade follicular lymphoma have an aggressive course. Indolent lymphomas are generally incurable, but they survive. However, they survive many years with remarkably stable disease, even in the absence of specific therapy. So what's the approach? See, remember, in a case of a low-grade NHL, it is the architecture which is the king. There is so you have to assess whether there is architectural effacement. And not only that, you have to think about what is the degree of architectural effacement. Is it partial or is it complete? Now then we have to assess what is the pattern of infiltration. Is it a diffuse or is it nodular or follicular? Is it a mantle zone or is it marginal? And then we have to assess the cell size. For this, we have to compare each lymphocytes. As you can see here, these are the lymphocytes, along with the endothelial cell, which is here, or a histiocyte, which is here. After this assessment of low power and high power, we will go into the immunohistochemistry, which is doing a very basic marker initially of CD20, CD3, and Ki67, followed by the varying patterns, which I will discuss later on. So, in a nutshell, these are the four major types of low-grade B-cell NHL, starting with the chronic lymphocytic leukemia or small lymphocytic lymphoma, which shows a diffuse or a pseudofollicular infiltrate, along with some proliferation centers. Here the cells are round, and the diagnostic immunohistochemistry is CD20, BCL2, CD5, and CD23. Then we come to the marginal zone lymphoma, which should be characterized by marginal zone expansion, along with interfollicular monocytoid cells and follicular colonization. Here the cells would be irregular with clear cytoplasm, and remember, in a case of marginal zone lymphoma, you will not have any specific marker. It is the exclusion of other low-grade B-cell NHL that, along with the morphology, that will nail the diagnosis. Here, CD20 and BCL2 is the prototypical marker, followed by CD43 in some cases. Then mantle cell lymphoma, which is characterized by a diffuse or a nodular infiltrate with the mantle zone expansion and an atrophic germinal center. Here the cells are irregular, along with CD20, BCL2, CD5, cyclin D1, and SOX11. These are the varied immunohistochemical markers which will enable us to make the diagnosis of a mantle cell lymphoma. Then it is the follicular lymphoma, which are monotonous follicles you will see along with cleaved nuclei, and CD20, BCL2, BCL6, and CD10 are the characteristic markers. I will come to these cases one by one. So this is a 61-year-old female, swelling in the submental region with 6 months duration, painless and slowly growing. What we have got here is a lymph node where the architecture is effaced, but as you can see, its vague follicles are there. The sinuses are not patent, which is another indication that there is a neoplastic process going on. However, there is no extension into the perinodal adipose tissue that you can see in this field. So on high power, you have to see the cells. So the cells are predominantly small lymphocytes with clumped chromatin, occasional prominent nucleoli with occasional pro-lymphocytes, and sometimes you can get a para-immunoblast. So what you do in this, you think it is a lymphoma, then you do your usual markers. So this is the CD20, which shows which shows the heterogeneous staining of CD20. The CD20 is very dark staining here along with light staining in the two areas, which is the characteristic sign of this entity. Then you look at the CD3, which is staining the T lymphocytes. But when you look at the CD5, you see this number of cells which are staining for CD5 are much higher in comparison to the number of cells staining for CD3. Therefore, you should entertain the diagnosis for CD5 positive low-grade B-cell NHL and do your CD23 and cyclin D1. So here comes the CD23, which is wall-to-wall positivity. So this is a case of chronic lymphocytic leukemia or a small lymphocytic lymphoma. Now, in real life, you will this is a case which you will not get too often because most of them can be diagnosed with flow cytometry. So it is only when they're thinking of a diffuse large cell transformation, then only you will be able to pick it up. So CLL, SLL, this is a disease of the elderly, predominantly occurs in 70 years or around that age group, although it can occur in young adults as well. Peripheral blood, bone marrow, liver, and spleen are the organs which are involved. And there are proliferation centers which are composed of small lymphocytes, pro-lymphocytes, and para-immunoblasts. So then we have got these atypical CLL in which cases have pro-lymphocytes between 15 to 55%. These are cells with larger nuclei, dispersed chromatin, and small nucleolus. Primarily involvement of the bone marrow and peripheral blood, and primarily nodal-based disease, SLL. The other thing is a histologically aggressive CLL, which is characterized by large, pale, confluent proliferation centers and increased larger cells. Here, the Ki67 is more than 40%, and a prognosis is intermediate between a typical CLL and a DLBCL, which is called the Richter's transformation. So very often you might get a biopsy in which the clinician is querying the fact that we know it is a CLL, but there has been an increase in the size of the lymph nodes. Patient is an anemic. I want to know from you whether there is a diagnosis of whether it has transformed into a diffuse large B-cell lymphoma. So where there you have to look at this cells. As you can see, some of the cells are quite big with very prominent nucleolus. This is called para-immunoblast. And when there are sheets of it, it is most likely to be a DLBCL. But when you are falling short of making a diagnosis of DLBCL, this is an entity which you might hope to offer, might want to offer to the clinician, in which you're not sure whether it's a DLBCL. So CLL transformation most often occurs into DLBCL, more than 95%, but sometimes it can happen like Hodgkin-like cells or pro-lymphocytic transformation, in which you can get sheets of cells like a diffuse large B-cell lymphoma or a CLL coexisting with a Hodgkin lymphoma. Next case is of a 40-year-old right cervical lymph node. At this power, you can see that at this magnification, you can see this very nice lymphoid follicles here, but there is a big area in which you do not see those lymphoid follicles. So when we go on to the other areas, there's a very sort of nodular / follicular infiltrate, which is effacing the lymph node. Here at this, in this field, you do not see any reactive lymphoid follicles. At this power, you can see this is a reactive lymphoid follicle. As you can see, this is fungible body macrophages surrounded by a very expanded mantle zone, which you can see here. And when you look at the high power, the cells are small to intermediate with irregular cleaved nucleoli, irregular cleaved nucleus. Sometimes people say you can get hyalinized vessels, but it's not often the case, especially in a core biopsy, which we are increasingly getting these days. So this is the CD20. You can see that this is the reactive follicle, which is darkly stained, surrounded by this expanded zone of CD20 positive cells, which sort of proves beyond doubt that this is a very predominant B cell population. Again, when you look at the CD5 and the CD3, both are T cell markers, but CD5, as you can see, is much more than CD3, gives you the first indication that this could be a case of mantle cell lymphoma, because then you have to do your CD23 and a cyclin D1. This is the CD23, which is highlighting only the dendritic cell meshwork and not anything more. This is the BCL2, which is negative in the follicles, but it's positive in the immediate vicinity, which is the mantle zone. Cyclin D1 shows sort of weak heterogeneous staining here. So this is a case of mantle cell lymphoma. It is classically a malignancy of naive B cells associated with poor prognosis, happens to middle-aged and older patients, and it happens in lymph node, blood, spleen, and bone marrow involvement. It can also present as GI polyps. Most of these are associated with T1114 with overexpression of cyclin D1. A small proportion of cases can be cyclin D1 negative, and these show overexpression of SOX11. There are patterns such as nodular, mantle zone, and diffuse patterns. The variants which we have to be careful about is the blastoid variant, which is characterized by greater than 10 mitosis per 10 high power field. The pleomorphic variant, in which it can be mistaken with a cyclin D1 expressive DLBCL, or the other patterns are CLL-like or the marginal zone-like. A PI67 or more than 30% is associated with an adverse prognosis. Therefore, one needs to mention that in our histology reports. The next case is of a 50-year-old male, lymph node, left groin enlarged. So at this power, the architecture is totally effaced by these big follicles, which are closely packed. There is attenuated mantle zone, or there's no marginal zone. We do not see the tingible body macrophages. We do not see our paracortical area. So this is a case in which there is complete architectural effacement. At high power, we can see these cells which do not have any macrophages. There is almost a very negligible rim of mantle zone, and at this power you can see these cells which are irregular cleaved cells, which are centrocytes, along with some centroblasts, which are the larger cells like this. So when we do our markers, the CD20 is showing strong diffuse staining within the follicles. CD10 is positive here within the highlighting the follicular pattern. The BCL6 is again showing this positivity within the follicles. And the most important stain here is the BCL2, which shows that this is a case of CD20 positive B cell population which is expressing BCL2, which is expressing BCL6 and CD10. This is the CD21 highlighting the dendritic cell meshwork, and the Ki67 showing which is much lesser than reactive lymph node, and it is sort of spread out throughout that follicle without the zone. So this is a follicular lymphoma grade 1. Now, how do we classify the follicular lymphoma into different grades? So we have to look whether there are centrocytes and centroblasts. So the number of centroblasts per high power field is the key to grading of follicular lymphoma. If it is less than 5, it is follicular grade 1. If it is 6 to 15, it is follicular grade 2. And if it is more than 15, it is follicular grade 3A. And if an area is composed only of centroblasts, it is follicular grade 3B. So we'll just take you through some of the different facets of this follicular pattern of infiltration, because it is imperative that you know the difference between a follicular hyperplasia and follicular lymphoma. So here we have got a very nice follicle which shows tingible body macrophages surrounded by a very dark, light and dark zones, which is positive for CD20, the CD3 staining the T lymphocytes in the interfollicular area, with occasional or few cases of with few CD3 positive cells within the follicles. Now the main thing is this BCL2 is negative within the follicles. When you interpret your BCL2, you have to always interpret along with your CD3 and look at whether the BCL2 staining cells are more than CD3 or less than CD3, because you have to remember BCL2 will stain some follicular helper T cells, and therefore you have to almost in your mind subtract those CD3 positive cells from your BCL2 positive cells to assess whether CD20 positive cells are truly expressing BCL2 or not. Then you have to look at the BCL6 and CD10 with the germinal center markers, and these are positive. So this is definitely a follicular hyperplasia. Next, we look at this follicular lymphoma. Here, compared to the previous one, you can see that the follicles are the follicles do not have tingible body macrophages. They do not have those light and dark zones. It is positive for CD20. It is the CD3 staining the occasional T cells. But compare this BCL2 with BCL3. So BCL2 positive cells are much more than the CD3. So BCL2 is being stained by some of the CD20 positive cells. And it is also positive for BCL6 and CD10. Therefore, this is a case of follicular lymphoma, because a combination of CD20 and BCL2 is, and along with BCL6 and CD10 is diagnostic of follicular lymphoma. Now I want to highlight a very important aspect of a follicular pattern of growth, which is the primary follicle. So here, as you can see, there are two follicles, the CD20 stain staining both the follicles. But just look at this area. So the CD3 is much less here, as you can imagine. This is a case of this is a follicle, so the number of T cell positive cells would be much less here. The BCL2 is positive here, but negative in the adjacent follicle. So immediately you would start to think that whether we are looking at follicular lymphoma. When you look at the CD10 is positive in the adjacent follicle, but it is negative in this in the follicle in which the BCL2 is positive. So this is possibly a case of a primary follicle, and you should not think of making a diagnosis of follicular lymphoma in situ based on the BCL2 positivity but CD10 negativity. So this follicular lymphoma is one of the Is the second most common mature B cell neoplasm following DLBCL. It is characterized by widespread nodal disease with splenic bone marrow and peripheral blood involvement. Most cases have a characteristic 5 negative, 10 positive, BCL6 positive, BCL2 positive immunophenotype, and 85% of the cases exhibit the hallmark translocation of T1418 involving the BCL2 and IgH. So these are mainly present in older adults with slowly progressive lymphadenopathy, and it has got an indolent clinical course to the extent that sometimes the clinicians might not even want to treat this patient. But there are some diagnostic challenges, and I'll discuss them one by one. So the first one is the follicular neoplasia, the follicular lymphoma in situ, or follicular lymphoma precursors. So the main thing here is it will demonstrate architectural preservation. So there will be no effacement of the architecture. However, one or more germinal centers with variably prominent populations of PD10 positive, BCL2 positive B cells are present that are monoclonal and exhibit the BCL2 IgH translocation. Strong BCL2 immunoreactivity is a hallmark feature of neoplastic cells, and this should be more intense than the mantle cells and the reactive T cells. The other important thing you have to notice is that there is no infiltration outside the germinal center, which should have an intact mantle zone. Now, the main differential diagnosis here is an early or partial involvement by follicular lymphoma. Now, it is possible that you might miss a follicular lymphoma in situ. It is not a problem because normally it is a fortuitous discovery. But it is important not to miss a partial involvement by follicular lymphoma. So what is the difference between in situ follicular neoplasia and partial follicular lymphoma? Partial follicular lymphoma are larger and they cluster together, resulting in a partially effaced lymph node active. They display at altered mantle zone, exhibit variable intensity of BCL2 staining. And this is only fortuitous discovery in 2 to 3% of lymph node resected for other than a lymphoma. Only 6% of this isolum in situ follicular neoplasia will eventually progress to an overt follicular lymphoma, and this will have indolent behavior of isolated of in situ follicular neoplasia. Patients should be evaluated for systemic disease because there might be something else going on in the patient, and the lymph node that we have got is only showing in situ follicular lymphoma. So the main thing to alert the physician is that to look for other sites where there might be a proper follicular lymphoma going on, or the other possibility is for us, for the pathologist, it's not to miss a partial involvement by follicular lymphoma. Simultaneous occurrence of overt follicular lymphoma and isolate and in situ follicular lymphoma in the same lymph node can occur, and BCL2 sequencing provided evidence that both in situ follicular neoplasia and overt follicular lymphoma can originate from the same clone because they share the same BCL2 IgH sequence. FL with follicular lymphoma with localized extranodal presentation. It's a primary duodenal follicular lymphoma which is characterized by a usually localized lymphoid infiltrate with a crowded CD10 positive BCL2 positive centrocyte-rich follicles with BCL2 rearrangements. Follicular lymphoma here are confined to the ovaries is another sort of extranodal presentation which is characterized by low-grade, high-stage BCL2 positive group and a high-grade, low-stage BCL2 negative group. Patients in the later group, that is the high-grade, low-stage BCL2 negative group, tend to have a favorable outcome, has also been reported for high-grade, low-stage follicular lymphomas presenting in other extranodal sites such as the thyroid and the spleen. So this is a typical example of a primary duodenal follicular lymphoma. We've got a duodenal biopsy, which normally presents as a polyp. The other lymphoma that can present as GI polyps is a mantle cell lymphoma. So here you see very nice follicles here, which are CD20 positive, BCL2 positive, and CD10 positive. So this is a classical follicular lymphoma. But when do we have to alert the clinician? When there is extensive involvement, high-grade cytology, and infiltration into the muscularis propria. It should raise concern about a systemic disease, and that is what is more important in trying to get to the bottom of the diagnosis. Predominantly diffuse variants of follicular lymphoma. This is another area where people can get confused with diffuse large B-cell lymphoma, and the report should specify that whether you are indicating whether it's a diffuse variant of follicular lymphoma, whether you are thinking of a transformation to a diffuse large B-cell lymphoma. So as you can see here in this picture, there are very nice follicles here. But sometimes the needle can go through here. And this is where it can create a problem. So because follicular lymphoma with a predominant diffuse growth pattern is a variant which is composed of centrocytes and centroblasts, and with a growth pattern less than 25% showing follicular. So this is a CD21, which is showing a loss of dendritic cell meshwork. And there you see the BCL2, which is staining much less within the follicles, but a little bit more within the diffuse areas. So this is a real problem in core biopsies, because in core biopsies, as soon as you see the lack of CD21 meshwork, you sort of almost think of a diagnosis of DLBCL. But here the cytology cytology would be helpful, because if it is a high grade cytology, then you're thinking of a follicular grade 3B, and it is immaterial whether you call it a follicular grade 3B or a DLBCL. Both would be treated the same, even if you get that wrong. But if you get a low grade cytology with the CD21 loss of dendritic cell meshwork, you should always think of diffuse variant of follicular lymphoma, and you should clearly state in your report that this is not a transformation of diffuse large B-cell lymphoma. This is a diffuse variant of follicular lymphoma. As the case, the clinical stage is usually low and large, but localized inguinal tumors are characteristic. So what are the immunohistochemical pitfalls? I've shown you one case of primary follicle in which the B cells normally express BCL2, which creates problem. But in this case, BCL6, CD10, HGAL, LMO2, these are the germinal center markers which can help. Now, low-grade follicular lymphomas will stain positively for BCL2 in 85 to 90% of cases, while the high-grade follicular lymphomas will stain positive for BCL2 in 50 to 70% of the cases. So as you can see, there's a 15 to 30% cases of follicular lymphoma which will be negative for BCL2. And there, your morphological assessment should be the key. Because even with a negative BCL2, if you morphologically think this is a follicular lymphoma, you should raise the suspicion. You should ask, you should look for doing other markers, other clones rather. Normally, we do the BCL2 clone 100 of the DECO antibody, but you should always look to double check with your E17 and SP66 antibodies, because sometimes what is negative with one antibody can come positive with another antibody. If you do not have, you must refer it to a higher center where when you are thinking that this could be a BCL2 negative follicular lymphoma. Or you can also do the translocation, but it is likely that it will be negative. Other problems that can happen is CD10 and BCL6 negativity may be observed in some cases of follicular lymphoma. Uh, this is predominantly seen in bone marrow infiltrates and in the leukemic phase of follicular lymphoma. HGAL or LMO2 can also be useful for detecting follicular lymphoma in extranodal sites, especially cases that lack the CD10 and BCL6. Here it is useful to rule out a marginal zone lymphoma where cases which lack CD10 and BCL6. HGAL expression is reported to be more sensitive than LMO2, CD10, and BCL6 in detecting follicular lymphoma. And LMO2 is not specific. It can be expressed in 88% of BLLs, 5% of CLLs, and 41% of mantle, follicular, and Burkitt lymphoma. A few words about Ki67 and follicular lymphoma. First thing, it has got no role in grading of follicular lymphoma, but it has got a prognostic indication. So as you can see, as your grade of follicular lymphoma increases here, the Ki67 is increasing. So these are three papers which show sort of around 20% in the grade 1, around 30 to 40% in grade 2, and much more in grade 3. So this is a case of low-grade follicular lymphoma with a high proliferation index. So this is an entity, very nice, closely packed follicles with attenuated mantle zones, which is positive for CD20, positive for BCL2, but with a high Ki67. So you should alert the clinician that although it is a low grade, but this has got a higher or an inferior prognosis. So this is scattered dot plot in which, as you can see, all the grade 1 follicular lymphomas are clustered with a Ki67 between 0 to 20%, grade 2 between 10 to 30%, and grade 3 is a more varied between 15 to 60%, and this is the follicular lymphoma in transformation. However, there are some outliers, as you can see here. These are the outliers which have, despite being low grade based on the number of centrocyte and centroblast count, are clearly having a high Ki67. So what to do? You retain your WHO grading, but you add a comment that this low-grade follicular lymphoma with a high Ki67 or proliferation index might pursue a more aggressive course. So in conclusion, low-grade high proliferative index follicular lymphoma appears to be a subgroup of follicular lymphoma with a clinical behavior more akin to grade 3 follicular lymphoma. High IRF4 and MUM1 reactivity in low-grade follicular lymphoma has recently been reported to be predictive of a poor outcome. Next up is follicular lymphoma with monocytoid features or marginal zone differentiation. So what happens is, this is the follicle, as you can see here. Outside the follicle, there is this proliferation of monocytoid or marginal zone cells, which points to marginal zone differentiation. So what it looks like? It looks like small cells with abundant clear cytoplasm. This show frequent downregulation of CD10 and BCL6, making it even more difficult to diagnose. This would be positive for CD20 and BCL2, which is also seen in marginal zone lymphoma, but this can be negative for CD10 and BCL6, and therefore here the role of LMO2 or HGAL comes into the picture. T1418 and BCL6 rearrangements by FISH is very useful in proving that this is a follicular lymphoma. So this is another case in which, as you can see, these are very nice sort of follicular growth pattern along with these follicles and this marginal zone differentiation and the cells with small round cells with clear cytoplasm. Then comes transformation of follicular lymphoma. The current criteria for transformation is a diffuse growth pattern with an increase in centroblasts to more than 150 per 10 high-powered films. Although most hematopathologists would consider transition from follicular grades 1 to 3A, transition from follicular grades 1 to 3A to 3B as transformation as well. Follicular grade 1 to 2 to follicular grade 3 is also progression. And follicular lymphoma may transform rarely into Hodgkin lymphoma, plasmablastic lymphoma, histiocytic sarcoma, or precursor BALL. Lymphoplasmacytic lymphoma is a B-cell neoplasm which is composed of a mixture of small B lymphocytes, plasmacytoid lymphocytes, and plasma cells. Bone marrow and peripheral blood are most commonly involved, whereas lymph node and spleen are involved in a small subset of cases. Mature B-cell lymphomas associated with Waldenstrom macroglobulinemia, which is defined as primarily bone marrow involvement with presence of an IgM monoclonal paraprotein and MYD88 mutation. So what are the symptoms? They present with weakness, fatigue, anemia, and hyperviscosity with an elevated serum IgM protein, infiltration of bone marrow and other tissues by lymphoma, and paraprotein deposition in tissues. IgM-related problems include coagulation disorders, cryoglobulinemia, neuropathy, and cold agglutinin hemolytic anemia. Predominantly seen in bone marrow as an interstitial or diffuse pattern, and the lymphoid infiltrate is predominantly composed of small lymphocytes and mixed with plasmacytoid lymphocytes, as in here, and plasma cells. The histological findings of LPL in lymph nodes are something that is a bit different. You have here got patent sinuses, scattered small or hyperplastic residual germinal centers, and lymphoma cells proliferate in the medullary, interfollicular, or paracortical areas. And these cases show architectural distortion or completely effaced architecture. Cytologically, there is a relatively monotonous proliferation of three types of cells: small lymphocytes, plasma cells, and plasmacytoid lymphocytes. These are negative for cyclin D1, and proliferation rate is also low by Ki67. So this is a very nice example of a lymphoplasmacytic lymphoma, which you get very few. And so you can see very nice patent sinuses here. And there is this sort of proliferation by a small lymphocytic population. Here, these are the small lymphocytes, which are strongly positive for CD20 with a very low Ki67. So even if you give it as a low-grade B-cell NHL, that's fine, but you can sort of, if it's better, if you can subtype it. So a nodal marginal zone lymphoma is the last of this category. So we've discussed PLL, SLL, mantle, mud, follicular, and LBL. Now we come to the nodal marginal zone lymphoma. It is a group of clinically indolent B-cell lymphomas which are postulated to derive from memory B lymphocytes in the marginal zone of secondary lymphoid tissue. So this morphologically resembles the extranodal MALT or splenic marginal zone lymphomas. Patients lack clinical evidence of extranodal or splenic disease. So there is localized or generalized lymphadenopathy. The important thing is to rule out an extranodal marginal zone lymphoma, and these are cases which express B-cell markers with CD43 expression in 20 to 75% of the cases. Sometimes you can get aberrant expression of CD5 and CD23. Now, if you get both, you are in a problem, but it is your morphology and the pattern of infiltration that will determine whether it's a marginal zone lymphoma with aberrant CD5 or CD23 expression, or it's a CLL-SLL. So this is again a lymph node in which you can see very nice follicular pattern, and at this power they are looking very pale what you see is a very atretic germinal center surrounded by this expansion of this marginal zone, which are cells with clear cytoplasm. What is showing is the CD10 positive and surrounded by, which is the atretic germinal center. And this is what is characteristic. You will have an atretic germinal center surrounded by these CD20 and BCL2 positive cells, which are going to be your neoplastic B lymphocyte population. Morphologically heterogeneous small B cells, including marginal zone or centrocyte-like cells and cells resembling monocytoid cells, scattered immunoblast and centroblast-like cells are present. Plasma cell differentiation may be prominent, and this might cause a problem with LPL, nodal plasmacytoma, or IgG4-related lymphadenopathy, in which case you will do your CD138, kappa, lambda, cyclin D1, CD56 to try to differentiate between a LPL or plasmacytoma or a marginal zone lymphoma with plasmacytic differentiation. So to conclude, accurate diagnosis of most mature small B-cell lymphomas can be achieved with a meticulous and morphological evaluation and a concise immunohistochemical panel. Now, however, we might emphasize the fact that architecture is the key. In core biopsies, architecture is difficult to identify. However, we have to train ourselves to get these core needle biopsies, to identify these core needle biopsies, to identify within the core needle biopsies the degree of architectural effacement. Discussion with the treating physician is recommended in case you are unable to offer a definitive diagnosis. Sometimes it can happen that we are able to offer only a low-grade B-cell NHL. Sometimes we are able to offer that this is a CD5 positive small B-cell lymphoma, and we can't sort of take it any further because maybe both the 23 is positive or the cyclin D1 is negative and this one 23 is negative. And in case of doubt, you do not hesitate to ask for an excisional biopsy of an accessible site. So with these few words, I sort of conclude my lecture. Thank you.
Thank you, Dr. Debdeep. Thank you so much for taking all that trouble. Excellently presented lecture. Thank you so much.